Hi, I'm Georgie Pipkin. Welcome to the Baptist Health Newsroom. We have a very exciting Facebook Live today. We are so lucky to have a great panel of experts with us to talk about sleep. It's National Sleep Week, so it's such an appropriate time. So let me briefly just introduce everybody. We have the neurologist, a famous Facebook Live, famous face around here that we love to call on for his expertise. Dr. Jaramillo, we're happy to have you. He's with our Neuroscience Center. And our medical director of the Baptist Health Sleep Center, we have Dr. Grant with us today. And we have sleep psychologist Dr. Marcy Wasman. So thank you all for being here. We're really excited about this topic. We've already been getting a ton of questions, really because we had, this week was kind of a loss of an hour for some people, and it's affected them. So we're happy to have you guys all here today to talk about it. So let's jump right in. As you guys have questions, feel free to plug them into the comment section of Facebook, and we'll get to as many as we can today. Let's start with the guidelines of sleep. So Dr. Jaramillo, let's start with you. Talk to us about what's the recommendation for both adults and children. What's a good amount of sleep, and what are some of those, pinpoints that we should know?
So recommended sleep duration really depends on your age group.
Okay.
It also depends on your personal requirement, which can vary from person to person. Back in 2015, experts that are associated with the National Sleep Foundation kind of tweaked the recommended sleep duration for each age group. They added some new age groups like older adults, patients that are 65 and older. Dr. Grant, you're safe, you're not in that group. So with the newborns, 0 to 3 months, it's recommended that they sleep from 14 to 17 hours. I'll jump a little bit to school-age kids, which is really 6 to 13, and that's recommended 9 to 11 hours. Teenagers are 10 to 12 hours, and then adults, which ranges from 18 to 65, it's recommended that those patients get between 7 and 9 hours of sleep.
And those hours is a consistent 8 to 12. Those ranges are consistent. Not like you can count an hour for a nap, and this, maybe for infants they've spread it out into a different morning routine, afternoon routine. Does it make a difference if it's all together?
Total sleep time.
Total sleep time.
Right.
Okay. So talk to us a little bit about, we hear people all the time, either with their friends or socially with coworkers, I got the worst sleep last night, or I'm so tired today, I could use a nap, 3 o'clock, especially in Miami, cafecito comes out, and people are tired. So Dr. Grant, when you hear those sorts of things, should a friend or a colleague say, maybe you should check that out, or kind of what's your recommendation?
So Georgie, what we see when we're seeing patients, we typically see people who say, listen, I'm not sleeping well at night, or I'm sleepy during the daytime. And they can both be related to each other. And one of the things that we have to figure out when we see a patient is, gosh, are they getting enough sleep? Because the most common reason for being tired or sleepy during the daytime is just insufficient sleep. But then we have to figure out, well, are they getting sufficient sleep, but is it bad sleep or interrupted or fragmented sleep? Or is there something else that's going on, perhaps a different disorder of sleep that could be causing them to be excessively sleepy during the daytime? So it's very much kind of a detective work of trying to figure out what the best diagnosis is and then what the best treatment is for the patient.
So let's dive a little deeper there. Can you talk about maybe the top or most common, I should say, sleep disorders, and what are those?
So typically the most common things that we see in the sleep clinic and the sleep laboratory are sleep apnea.
Okay.
And sleep apnea, there's 2 different forms of snoring. So snoring can be from the upper airway, which isn't really that dangerous, it just makes noise. But it can be sleep apnea as well, where as you go into deeper and deeper sleep, your throat closes off so much that it's like a kinked hose, and then not enough air gets into your lungs, not enough oxygen goes to your brain, and your brain gives you a nervous system battery jolt to start breathing again that's no different than as if you were frightened. And when those battery jolts are happening all night long with a low oxygen level, it can interrupt your sleep, and it can make you tired and fatigued during the daytime, but it's also a risk factor for other things like high blood pressure, heart attack, stroke, an irregular heart rhythm, diabetes, depression, and now we think it's a risk factor for all forms of cancer because it can affect your immune system.
Wow.
One of the other major disorders that we see is insomnia, that Dr. Wasman is a specialist in. And insomnia is typically trouble getting to sleep, staying asleep, getting up too early in the morning, not being able to get back to sleep, or feeling unrefreshed, and any combination of that. And it can exist with other sleep disorders as well. But now we know that not only sleep apnea can fragment your sleep and be contributory to all these risk factors like high blood pressure and heart disease, but even fragmented sleep from insomnia can do that as well. And then we see other things like sleepwalking and doing bizarre behaviors at night, sometimes even violent behaviors at night. We see patients with restless leg syndrome, which keeps them up at night or can keep them from being able to fall asleep at night. So it's really a myriad of different things that we see. And the trick about sleep medicine that's different than a lot of other specialties is you can have multiple sleep disorders occurring all at the same time. And then you have to figure out the best way to treat them, which to treat first, or to treat them together, concomitantly. So that's typically what we do all day long.
I was doing some research, before having this discussion, and I saw, all these different types of sleep disorders, but then I saw something that said, there's a difference between a sleep disorder and sleep disturbance. So can you explain the difference and what that means, and is there a variation of options for people?
So a sleep disorder can cause sleep disturbance, a disturbance of sleep. But you can have a disturbance of sleep from something as simple, Dr. Wasman is a psychologist that I literally deal with every single day with my patients. You can have a disturbance of sleep because your dog is in the bed with you and getting up and nuzzling up against you. It's because your baby is co-sleeping with you. And that's not necessarily the same thing as a bona fide sleep disorder such as sleep apnea or another disorder which could be fragmenting your sleep. But they can all be kind of intermixed with each other.
Is there, and maybe this is a question for Dr. Jaramillo, is there a way that somebody might develop a sleep disorder? Are there certain things that people do in their normal routine that would make you higher risk, or how does that look like? Or is there family history? You hear of all these different types of diseases. Is there a common thread there for sleep disorders?
The common thread are risk factors, and those can vary from sleep disorder to sleep disorder. So you mentioned one, hereditary risk factors, so things like insomnia, sleep apnea, they're definitely hereditary risk factors. Patients that are overweight have a risk factor for having sleep apnea, but if you practice enough sleep medicine, you realize that people that are not overweight can have sleep apnea as well, so you have to sort of keep your mind open to that. There are certain anatomical risk factors. The airway is a structure that's made up of different tissues, and there are certain anatomical features that put people at risk for having sleep apnea, for instance.
And Dr. Wasman, let's turn it over to you. I know that you work closely with our team here at Baptist, and they often refer to you as a sleep psychologist. So talk to me a little bit about that process. At what point do you start seeing the patient and kind of take control of maybe their treatment plan or some recommendations, and how we get over to your side of the house?
Well, get over to my side in a number of ways. A lot of people are referred by their physicians, whether it's like Dr. Grant, Dr. Jaramillo, they have a patient and they see that there is definitely a strong component that's psychological, that's behavioral, that is more my side of it. I get referrals. Sometimes people will just self-refer themselves, talk to a friend. It's people who are unhappy with their sleep in some way. It may be that they know that they need to be using a CPAP machine for their apnea, and they're just not comfortable with it. They can't get themselves to adjust to it well. And so they'll come to me to help them get used to the machine so that they can do that.
So if somebody thinks that they're possibly having a sleep disorder, they want to go see somebody, they may go to maybe Dr. Grant first at the sleep center, and then once you've kind of given them a diagnosis of some sort, or you've kind of evaluated them, you may then say, okay, maybe it's time for you to go see Dr. Wasman.
So what I'll say to a patient is, listen, you've got insomnia. You've had insomnia for years or decades, and I'm going to try to help you, but if you look at all the literature, it shows that the best way to treat insomnia is, number one, make sure that it's not another sleep disorder, but number two is a combination of what we call cognitive behavioral therapy that Dr. Wasman will talk about. That's a specialized form of therapy that's geared towards helping patients with insomnia, and maybe medications. And so what I'll tell the patients, if I just give you a medicine today, you're not going to be much different a year from now. But if I have you see Dr. Wasman and you do this cognitive behavioral therapy in addition to what we're doing, you're prone to be much, much better over the next several weeks or months compared to that if we didn't incorporate this.
Yeah, can you expand a little bit about what that is and what is it?
Absolutely.
Sure.
Yeah, it really is. Cognitive behavioral therapy is a group of therapies. It's kind of like an umbrella term to cover different things. First, it involves assessing the patient and finding out exactly what's going on. And if you're going to go strict definition of it, it involves, first of all, getting sleep hygiene on track, which are the little behaviors, things that people are doing that irritate sleep, making sure one's sleep environment is appropriate, which is cool, dark, quiet, comfortable. Sleep hygiene alone, if somebody really has an insomnia problem, is not enough. And then we go further. We address the cognitive part, which is somebody's thoughts. People often have thoughts that are associated with increasing stress and arousal in bed, so they worry about either sleep or they're worrying about work or something else, and bed becomes a place where that happens, so we work to redirect their thoughts. There's a component connected with that called stimulus control, where what happens is unconsciously people form connections with things. They're just automatic. And what we want for good sleep is that connection with bed to be comfort, relaxation, and sleep. But what it becomes for people with sleep problems is a place to dread, a place to be anxious. So they may be tired, and as soon as they hit the pillow, all of a sudden they're wide awake. This is somebody who 5 minutes before was falling asleep on the couch. So we work with that to get those things out of the bed and keep the bed in a way so that it is really more for somebody being relaxed and comfortable, conducive for sleep. So we have those components. We also often bring in something called sleep restriction. And you would think when somebody's not sleeping enough, the last thing you want to have them do is sleep less. But in certain cases, and we do it based on keeping sleep logs for a couple of weeks and figuring out what's the right amount of time for them, we actually restrict their sleep, which allows them to build up more sleep drive. And sleep drive is very biological. Chemicals get built up in the body, so we strengthen the sleep drive, and that gives another push to their sleep. We also bring in things like relaxation techniques. We can bring in dealing with circadian factors turn out to be often a really big part of what's happening with people who have sleep problems. Things are not matching up. They may be eating on one schedule, sleeping on another schedule, and in order to have good sleep and deal with insomnia, it's kind of like, I think of it as one of those old-fashioned clocks that have a lot of little wheels in them. And if one wheel is not connecting right with the other, well, then the whole system breaks down.
Right.
So that's another thing we pull in, is working with their circadian factors, or if their sleep schedule is either too early or too late, we try and move that to a better range so they can sleep better.
So you brought up an interesting point about sleep hygiene. I don't think I've ever heard that word used, but as you explain it, I think it's so important for those that maybe not even have a sleep disorder. Maybe they're, they have a decent routine, but they're watching Netflix on their phone in their bed before they go to sleep, or now with cell phones, that light in the room, or even with kids. Can we expand a little bit on sleep hygiene, maybe for the group, if there's any particular tips that would be helpful? You mentioned a cool, dark room. What other things for the general public, for adults, for kids, can minimize the distractions when they're going to bed and make it a calming environment, as you mentioned? And maybe we'll start with you and go around if there's some tips there for that most appropriate sleep hygiene, as you mentioned.
Well, you're absolutely right. Getting the light out of the bedroom, and actually getting the light turned down even earlier, because light affects melatonin production, and we want melatonin to be turning on 2 to 3 hours before sleep time. So that light needs to be getting dimmer. We need to kind of match Mother Nature, match the outside. But we're also looking at things like, when's the last time somebody had caffeine and how much, alcohol, Those are two of the things on what I call my list of sleep assassins.
For new moms that are, want the glass of wine before bed. I have lots of group chats with moms, and they're always like, gotta have my glass of wine before bed. So that's a big no-no.
That's
Yeah.
a huge no.
Yeah.
Yeah, because it may help you get to sleep, but then as it's wearing off, you have a rebound effect, and guess what? You're wide awake again.
So alcohol is there's a huge percentage of the general population that uses alcohol to try to get to sleep. And the reason is because it does make you sleepy initially. But it does a lot of really bad things. It's really poison to sleep. So what it does is it lets you go into light sleep, but it never lets you really go into the deep, refreshing, rejuvenating sleep. So it keeps you in that light sleep. You can rebound and be up during the night, even though it lets you get to sleep initially. The other thing that it does is it's a muscle relaxant. So if you even have a predisposition to snoring or sleep apnea, it can make you more predisposed to closing off your airway and not getting enough air at night. The other thing is it's a respiratory suppressant. So it tells your brainstem, that part of your brain that tells you to breathe, listen, you're so relaxed, you don't have to breathe as much. So the real problem where patients run into complications that can be quite serious is when they mix a sleeping pill and alcohol, because they're both potential respiratory suppressants, and then they suppress the breathing so much that you can literally stop breathing in the middle of the night. Another thing, and then I'll pass it on to Sergio, is that a regular schedule. This is something that I've worked with myself over the last several years has been quite helpful, is trying to keep a more regular schedule. So we were talking about it before the show today, is that what so many people do, including adults and especially adolescents, is you have one sleep pattern during the week, and then you try to make up for it during the weekend. Right. So you go to sleep at one time during the week, and then later on the weekend you think you're going to make up for it. But you can't really make up for it. Your sleep depth is not really made up for. It really still predisposes you to a whole bunch of things. And we even have a term for that. We call it social jet lag. So it's literally like traveling to another country on the weekend compared to where you were during the week. And it just wreaks havoc on your internal body clock or your circadian rhythm. And then there's some other things that we can do as well.
This is, I think, a good time to talk about how medicine really has to be very individualized, because our bodies are so different. And resiliency to sleep deprivation or even tolerance of alcohol and what it does to your sleep can vary from person to person. So it's very hard to try and give a recommendation, a very strict recommendation to sort of cover everyone. But as long as people know and keep in mind that when you send a mixed signal to the brain, then there's a much higher chance that it can become a problem, and a chronic problem. So if you are listening to music, or if you have a bright screen, or you're doing anything like keeping caffeine too close to your bedtime, things that are stimulating to the brain, well, that's a mixed signal, and eventually it can turn into a problem. So you have to sort of keep that in mind, is that our resiliency to these kind of factors can vary from person to person. But sleep hygiene, I think, applies to everyone. The more disciplined you are with these things, I think the less chance that this becomes a problem for you.
So one of the practical things that we'll tell people is, for instance, okay, if you're going to have a glass of wine, have it with dinner.
Right.
It's better not. If you have terrible insomnia, it's better just to lay off of it. But if you really enjoy it, try to have it with dinner, no later than 6 or 7 o'clock, say, and then it's not going to have such a dramatic impact. Caffeine is interesting, that some people can have a glass of coffee before they go to bed at night, it doesn't affect them at all, and other people can have a cup of coffee in the morning and it's affecting their ability to fall asleep at night or increasing restless leg syndrome and problems. Another thing for sleep hygiene is interesting is naps. We try to limit naps.
Yes,
I just had a patient the other day where the wife came in and said, listen, he's napping for 3 hours a day. And because he's retired, he has no schedule. He doesn't kind of care what his schedule is. So what I did is I limited his naps to like 45 minutes to an hour. And he's happy, she's happy. And the other thing is exercise. Exercise turns out to be a wonderful thing for insomnia and sleep hygiene for any age group, whether you're pregnant, non-pregnant, premenopause, postmenopause, young, old. And it doesn't have to be crazy exercise like you see, somebody's going to go buy a new exercise bike on TV and they're exercising like they're 22 years old. All you have to do is take a little walk around the block 3 times a week, and that can be enough exercise for you. And that's shown to be extremely beneficial. You just don't want to do it too close to the time that you're ready to go to bed. You want to do it a couple of hours before you're ready to go to bed, because that can be stimulating, but that can be helpful as well.
I have 2 very energetic little boys, and if they have exercised or played soccer all day, you can bet that they're going to sleep so much better. And I think it's a great example, because adults are similar, and I think we forget that, you know, if we exercise, we're actually going to be a little bit more tired and might sleep better. But I want to go back to the prescription medications, because I think melatonin became somewhat of a buzzword maybe a few years ago, and it's over the counter, and then there's also, you know, like the NyQuil, and here's some examples here. But I want to ask maybe Dr. Jaramillo, is this okay? Is it, you mentioned it might be case by case depending on the person and what they have, but in general, good, bad, not so much?
It really depends on sort of the frequency of use.
Okay.
And so if you use a Unisom or a Tylenol PM here and there once in a while, and it kind of gets you through a tough night, I think that's okay. I just think that using a crutch repeatedly, you kind of are sort of giving the power that you have within yourself to find sleep naturally to a sleep aid, or headphones in the ears, or the TV being on. So you want to sort of empower yourself and keep that power, so that, you know, you can find sleep naturally, especially as we age and as we get less efficient in sleep. It's very important to keep that in mind, that you don't want to sort of give up that power to find sleep naturally.
And what about prescription medication? At what point is it okay? And maybe Dr. Wasman, you can touch on this. If you're prescribing Ambien, for example, we hear about that a lot. Obviously, we're going to say, you know, seek medical advice on any kind of prescription medication, but at what point is that appropriate for a particular patient that might come in?
Well, actually, I'm not the one who does the prescribing.
Okay.
As
So
a psychologist.
So say
I apologize,
Okay.
but
So what I said earlier is that it's very important to combine the relaxation therapy and cognitive behavioral therapy and sleep hygiene with medicines, if medicines at all. Typically, all of the non-prescription, not all, but most of the non-prescription medications on the market, these that you've kind of put here, have what's called diphenhydramine, which is an antihistamine, Benadryl. And so Tylenol PM, Unisom, ZQuil, NyQuil, those medicines typically have diphenhydramine, which is what somebody would typically take for an allergy. They would take that because they were having hives or an allergy, and it tends to make people sleepy. So it's a non-prescription medication, and it's in most of the over-the-counter medications, and something that's other than melatonin. In the prescription medications, there's a whole realm of different medications that work by different mechanisms. And the point is that we have to discuss with just what Dr. Jaramillo was saying. It depends on the patient, depends on their age, depends on their other problems, depends on whether we want to make their sleep apnea worse with giving them a medication, depends on whether they have anxiety or not anxiety. But there are risk factors to every one of the different sleep medications. They can affect memory, they can affect sleepiness the next day and vigilance the next day. Some of them are associated with abnormal behaviors during the night, like sleepwalking or sleep eating without any recollection of having done that. They can be associated with waking up in the middle of the night and feeling paralyzed. You can have hallucinations. So the point is, there doesn't exist the magic bullet of a medicine that just kind of zips you into sleep. You have no complications. You wake up, you know, and that's it. And that's why we have to explain to patients there are risks involved with these. Sometimes they are indicated. You know, sometimes people's lives are so impacted by their inability to be able to sleep that they need something to help them kind of break that cycle. But we always try to stress the less medicine or no medicine is better.
So I think that's the key takeaway there. It's really not one size fits all, and really reach out to your physicians for guidance, and you know, less is best.
I'd like to just add something about melatonin, because its use is so widespread and people think, well, it's not a big deal.
It's over the counter.
But it can be a big deal. First of all, it is contraindicated for certain medical problems. It affects the immune system. We're now looking and thinking that it may affect insulin production. And the other thing that came out in 2017 was a big article where they analyzed different brands, and what they found was 71% of these pills that they tested what was on the label did not match what was in the pill.
That's scary.
So yeah, it's very scary. And the other factor is melatonin's main role is guiding the clock in the brain. And so if taken at the wrong time, it can actually make a sleep problem worse.
So let's talk about children. I think a lot of the people that watch us often are working moms or have busy schedules, and their kids come home from school, they have a ton of homework to do, they want to relax, or maybe they have an after school activity. Can we talk about, maybe they're eating dinner too late also? Can we talk a little bit about some tips for those parents that have children in various activities, and what we can kind of guide them to do for their sleep routine with their kids?
Sure, I see this problem all the time, and what happens is it happens with the school-age kids, it happens with the high school kids, and they've got their homework, they've got their after-school activities, they are coming home, eating dinner real late, then they're starting on their homework, and guess what? Either they can't fall asleep, or there's usually not enough time to get a full night's sleep. So what I first of all tell parents is to look and see how much are you packing into your child's day.
Right.
It may not be realistic, and is sleep what you want to sacrifice? I give them guidelines because people need to know that, first of all, if you kind of start backwards from looking at, well, when do you want your child to be able to fall asleep? Then you have to look from there, what time should they be finished eating dinner? This is part of that coordination of all the clocks and activities, because if a child eats dinner and you expect them a half hour to be able to fall asleep, or an adult, that's not a good thing.
No, that's good advice. I think looking at it backwards and say,
exactly. So sometimes what I'll tell parents, if they're, can't give up the sport, it's so important, it gets them home late, I said, well, give them dinner earlier, before the sport. They may not be used to having their dinner at 3:30, 4 o'clock, but give them dinner earlier. And then when they get home after their sport, give them just a light snack.
Great solution. Yeah.
But still, there has to be at some point a decision about how much schoolwork, how much, time with sports, and sometimes the numbers
it's
just
be
don't add up.
Give and take there.
Yeah.
If they're in soccer, swimming, and piano, maybe it's time to reevaluate and
and they're tough decisions because our culture now pushes all these things.
At what age, and really any of you can answer, are children diagnosed with a sleep disorder or any kind of sleep issue? At what point is there a recommendation for the parent to say, okay, I think it's time for you to come in, you're seeing these kinds of activities with your children, aside from building out that schedule? When should they make that appointment and come in and get evaluated? If they are seeing signs, or?
Yeah, I think parents are the ones that know the children best. So anytime they see either children being hyperactive, for instance, which is a common response to sleep deprivation in children, which is kind of opposite of adults. Or they're showing signs of being overly sleepy during the day, when they're underperforming academically, or having any form of behavioral issues. I think that's the time to consider the possibility of some issue with sleep, maybe not as the lone problem, but something that's making things worse. And I think it's a critical time because we develop our habits and our tendencies when we're young. So if you are allowed to have poor sleep hygiene as a child, and you're allowed not to exercise growing up, well, guess what? When you become an adult, things are going to probably stick. You're going to have those bad habits, and you're going to have a tendency not to exercise. So it's really a critical time to get children into really good habits.
Something that's interesting, way back in training, they used to think disorders like attention deficit disorder, ADHD, were just a special irregularity in chemical balance in children that just were acting out in a different way. And the thinking has changed dramatically over the last couple of decades, is that now we think exactly what Dr. Jaramillo just said, is that we think, gosh, maybe it's due to sleep deprivation. Whereas an adult, if you were sleepy, you put your head on your desk and you just kind of want to take a nap. But a child can act out and act out in different behaviors that are very different than an adult would be. So that's an important thing. So if it's poor performance in school, abnormal behaviors. Another thing is snoring. You know, two of my grandchildren at a very young age had sleep apnea that was addressed and treated appropriately and virtually cured for them. It's much easier to deal with it at a young age than it is often at an older age. But you can, for instance, have sleep apnea at any age. And so if you have significant snoring, or if your child is sleeping in a weird position, or if they stop breathing or snorting or gasping in the middle of the night, that's important. Another issue we were talking about that's very important before the session today is a thing that we often refer to as screen addiction. And we'll see that in adults, but especially in young children and adolescents. Now you can have a cell phone and an iPad and a computer and a Game Boy all in your room, and they can be quiet and silent without your parent knowing and totally, completely disrupt your sleep patterning. So we recommend that, listen, make it important that you charge your cell phone out in the living room, that you charge your iPad out in the living room, that there's no games allowed after a certain time, and that there can even be limits that you can place on the computer in a child's room, that it can only be turned on and off for certain times, because we talked about the light, and there are study after study after study that shows that children who have all those electronics in their room and that are allowed to use them, they have diminished total sleep time and decreased performance in school.
Yeah, and I think the change there too is a lot of the homework that we're seeing that they bring home is being done on the computer or the iPad.
yeah.
So it's like they got to do the homework. They've come home from their activity.
Yeah.
You got to squeeze in what you can, and then you're asking them, okay, we'll turn everything
Absolutely.
off and then go to bed. So you were going to jump in and say something.
Well,
like,
no, we had this session about screen time.
Yeah.
The last Facebook Live,
Yeah.
and looking at the literature that's out there, you realize that it's not just in the United States. This is a worldwide problem.
Right.
There's major, huge studies coming out of Iran, out of China, and children are just in front of a screen for too long.
Absolutely.
The unanswered question is, educational screen time versus non-educational, and just the content and the variation of that. We don't really know where to draw the line, to really guide us as to how much screen time, if it's educational, is too much. Is there such a thing? So these are unanswered questions.
Or maybe it's that mindset as it relates to sleep is shifting. Let's do the screen time, homework first, and then whatever is written maybe after, to give you that kind of space between bedtime and kind of, as you said, kind of plan backwards.
Yeah,
So-
because the light's going to shut down melatonin production or prevent it.
Exactly.
Yeah, and it's also what Dr. Grant said, which is teaching our children appropriate sleep-related behaviors. It's like they really, learn some bad patterns, and they keep it up after a while, and it's
persist.
really it's hard because it's really up to the parents at that point. If the parents can't get some control over it, the kids aren't going to be able to.
Right.
That's one of the things that always comes up in sort of pediatric behavioral neurology is limit setting. You have to, as a parent, know how to set limits, and for some people it's harder than others.
So we're going to pause briefly because we're getting some questions and people are interested, and we've talked a lot about sleep. So Gabriella's asking us, which sleep position helps you sleep best? Who wants to take that one?
So
Position.
it turns out that there are many myths that one position is
It's
better than another
other.
position, or one mattress or one pillow is better than, and it turns
There's
out
no magic.
that the simple answer is whatever's best for you.
Okay.
If you have a particular sleep disorder, for instance, if you have sleep apnea, it's going to be worse when you're on your back, or snoring is generally worse when you're on your back, and that's because just gravity allows your palate to fall back more easily while you're in a supine position on your back. And that's why one of the tricks is that if you you always see it on the commercials, that if you elevate the bed, sometimes that can diminish snoring. The problem with thinking about that from a sleep specialist point of view is even if you have diminished snoring, you can still have sleep apnea. So one of the important issues is you can't really tell whether somebody has serious or important snoring without doing a sleep study. And so if somebody has snoring and you just think, well, it's not a big deal, you can't really tell just by listening to it. You have to really do a more involved investigational studies. But the other thing is, number one, if you have sleep apnea and it's treated appropriately, you can sleep in any position. You don't have to choose a position. But if you don't have a significant sleep disorder, it turns out that probably the best thing for you is whatever's the most comfortable for you. And what Dr. Jaramillo was saying earlier and Dr. Wasman is that what's good for one person may not be. So there is not, I was just reading a whole review of mattresses and pillows and everything, and what you would think would be, because of the advertising, doesn't really pan out at all. And that it's whatever is best for you and whatever you're the most comfortable with, it turns out to be the best thing for you.
I'll make a small neurological plug here in that it may not have an effect on your sleep, but your pillow may have an effect on sort of your anatomy and sort of the alignment of your spine and things like that. So there are some things to talk about there. But in relation to sleep, I agree with Dr. Grant, yes.
Yeah, you do hear all those mattress commercials. You're going to have the best night's sleep
Yeah.
ever.
Yeah.
So you
Yes,
guys
it
heard it
does.
here from the Baptist Health experts that it's not a one-size-fits-all, but really what's best for you.
So I see, let me just answer this question.
Sure.
This question is snoring a sign of a sleep disorder? And the point is it may be, it possibly may be. As we said earlier in the conversation, there exists snoring that is just from what we call the upper airway, from a deviated septum or congestion or allergies. And it can make a lot of noise, but it's not dangerous. It's not really causing a lot of different problems in most cases. There are ways, unless it's disrupting your partner, unless it's causing problems with disruption from just the snoring. But it's not thought to, in and of itself, be terribly as worrisome as sleep apnea. However, as I just said a few moments ago, if there's snoring, you really need to investigate it, because it may be something concerning like sleep apnea, or it may not be, and you really need to investigate it to tell.
The adage we hear a lot is that everyone who has sleep apnea snores. Not everyone who snores has sleep apnea.
Good way of putting it.
But then I'll go back to what we talked about earlier in the difference between a sleep disorder and a sleep disturbance. It may not represent a sleep disorder, but it may be a sleep disturbance for the bed partner.
Yeah, we call that spousal arousals.
Makes sense. So Vivian's asking us, best way to sleep if the husband snores. Great question.
Yeah,
Or vice versa.
I think the short answer is in another room. But
I just read a study yesterday that said a third of couples of all ages sleep in separate bedrooms. And we see that all the time because I just had a patient this week who is now back in the same bedroom because her sleep apnea, her sleep apnea was treated, and now they're back in the same bedroom. But the point is, to that question is, it's better if you're not on your back. However, if your husband's snoring, you need to make sure that they don't have sleep apnea. And you can't just assume that it's something non-important, because it is important to treat that sleep apnea.
And Dr. Wasman, you were going to add something about that? Or just
no, I was going to say the same thing.
generally
You want to make sure that it really isn't, a serious
Something more
sleep
serious.
disorder going on.
Absolutely. So we have another question coming in. We mentioned melatonin gives her headaches. This is a particular person who's asking this question, Sheila, especially in the mornings. So why is that? Maybe, the time of day, or I'll let you guys answer.
That's hard to answer, I
Yeah.
think. I mean, there's placebo effect with sugar pills. So if you take melatonin, you can have a number of symptoms, and I'm sure a headache is there as a possibility. But is there a physiological direct connection? I can't think of one.
The other thing that's important, Dr. Wasman, the things that make you go to sleep at night or help you go to sleep at night is, first of all, what we call your sleep drive, that you've been awake all day long and you're sleepy. And the next thing is your circadian rhythm, what we call your internal body clock. And so when the sun goes down, it helps your brain to create melatonin. One of the things that people do in a mistaken way is they take their melatonin too late. So they'll take it right before they're going to sleep, which is pretty late, but they should be taking it earlier in correlation with sunset. So they should be taking it like at 8 or 9 or no later than 10 o'clock, depending on their sleep patterns. And a lot of people will take it late. But the other thing to realize with these over-the-counter preparations, what Dr. Wasman was saying, there's no FDA regulations on over-the-counter medications. So you may be taking one brand or a different brand or an off-label or whatever, and it may have a different preparation in it that isn't even melatonin. It may have something else in it, just the way that it was prepared by a certain company, because there are zero regulations on these companies. So I would try to at least stick with a recognizable brand, and the other point is to take it earlier. And then the other point is, Dr. Jaramillo and I are neurologists. There's another cause of morning headaches. So it can be from sleep disruption, and one of the classic causes or associated things with morning cephalgia or morning headaches is sleep apnea is kind of a classic presentation of morning headaches. So it's also important to make sure that if you have headaches that aren't resolving, to either see your neurologist or your doctor, or maybe even a sleep specialist.
One last thing on melatonin, and then we can put it in the cabinet.
Put it to rest.
Is that there are lots of doses out there, and people, it's very common for people to use, 10 milligrams, 20 milligrams. As a sleep specialist, I rarely recommend more than 3 milligrams at a maximum 5 milligrams. I wouldn't go higher than that.
For insomnia.
For instance.
So there are other sleep disorders that we see, for instance, certain violent behaviors at night, that much higher dosages of melatonin that are appropriate. But for the routine patient that has trouble sleeping at night, that's exactly right. They make it in typically a 1, 3, a 5, and a 10, but usually you don't need much more than a 1 or a 3.
In general, do you see more female or male patients? Does it matter? Is it a mix? Is there a particular age range that sleep disorders affects, or is it kind of all over the map?
I think it can be a little bit all over the map,
Okay.
but because we say sleep disorders, that runs the whole gamut of sleep disorders. If you talk about insomnia specifically, I think there are particular times in a woman's life that they tend to have a little bit more issues with sleep, menopause being one of them, when there are hormonal changes and there are effects in terms of sleep fragmentation and the consequences of sleep fragmentation. So as a neurologist, it's very common for me to see a patient who has frequent headaches, who is postmenopausal, who has issues with insomnia, who has maybe an anxiety disorder, who's also complaining of memory loss. So it's all connected.
Is there a connection also with Alzheimer's? I know that you can kind of speak to Alzheimer's as you treat some of those patients. Do you think there's a correlation there, or?
Right now we think that there's a bidirectional relationship with sleep disorders and Alzheimer's. So there's evidence that that circadian loss of organization of the circadian rhythm can actually be a marker of a potential degenerative condition to come that's starting to sort of unravel itself. And it's also clear that people that have Alzheimer's disease have a tendency to be overly sleepy during the day. They have sleep fragmentation. People as they age in general, even without Alzheimer's disease, tend to have what we call an advanced sleep phase disorder, where they get sleepier earlier in the day and they kind of tend to wake up earlier in the morning. It's a shift in that rhythm. So that's where we are right now. We think it's a bidirectional relationship.
Okay.
The other thing is with gender. Different sleep disorders occur in different genders more prevalently. So insomnia tends to be more prevalent in women. Sleep apnea tends to be more prevalent in men, but after menopause, women start to catch up. Restless leg syndrome is more common in women, but violent behavior is more common in men. However, the problem is that you think about these stereotypes and then you think, well, gosh, I can't have this. So I had a woman sitting on an airplane, and she said to the doctor next to her, gee, you think I could have sleep apnea? And he says, no, you can't, because number one, you're a woman, and number two, you're petite. You're not overweight. And both of those answers were wrong, because a third of the patients who have sleep apnea
jump in
are,
there,
are
or like,
skinny.
no, hey, I'm the sleep
I ran-
expert.
Yeah, I was on the
Yeah.
commercial and I did a, So the point is, a third of the patients who have sleep apnea can be skinny, and it's very common. We see, my joke is I see many women and men who both have it, and I say just wear your machines at night, and that keeps the romance alive. But there are different disorders, and you can see it in all different genders, and then in all different age groups of different problems.
So I think this is a fascinating topic. I think we can keep going for hours. Let's take a few more questions, maybe one more, and then I'd love to have final thoughts and maybe some tips for people. So last question here we have, can you catch up on sleep over the weekend? I think Dr. Grant, you kind of alluded to that and basically said no, but if you want to elaborate.
That's the short answer.
That's the short answer.
And the short answer is no. It's better than not catching up, but people think that, gosh, if you just do this mathematical calculation, I'm missing this way. And the point is you can't. And they just even did a formal study of patients who were limited in their sleep to 6 hours or less during the week, and then trying to make up with it on the weekends. And that's typically what many working adults do. They get like 6 hours, and then they try to make up on the weekends. We've all done that. And it turns out that it's better than doing nothing, but it really doesn't let you catch up. And then it affects your immune system. It affects a lot of your cardiovascular system. And it puts you at risk for a number of different illnesses. So thinking that you can catch up isn't helpful. Adolescents are like the best at doing that because they party on the weekends and think they can catch up and get up at 2 in the afternoon. But adults do it too, and it's not the best thing. If the best is to try to keep a reasonably coherent schedule between the week and the weekend. And even though it doesn't have to be exactly the same, just to have not tremendous variations.
The other point to make is that it really depends on how long someone has been sleep deprived for. So it's different if you sleep deprive yourself for a day or a couple days, or if you do it chronically.
Right.
Then your
Continuously.
response to that physiologically is going to be different too.
That's a very good point. So if you were sleep deprived for a day or two, you can make up for it. But the question was, can you make up for it on the weekends? And
Right.
so the answer on the
Long-term
weekends,
isn't
no. But
not
if, of
sustainable.
course, if
Yeah.
you've been sleep deprived for any particular reason, a medical illness or something, for a couple of days, then you can make up and rebound from it quickly.
So let's wrap up with some final thoughts. I know there's lots of questions. You can keep them coming in and we'll answer them throughout the day via our Facebook page. But let's do final thoughts. Dr. Wasman, any tips for anybody in general or anything we should know that we didn't touch on sleep from your perspective?
Well, from my perspective, I think it's knowing that if you've got a sleep problem that is persisting, take care of it. If, for example, it's something like insomnia, and simple things that you get out of sleep hygiene are really not doing the trick. Don't let it persist. Don't let it go for months and months, because we know the longer it goes, the more entrenched it becomes. And just to know that there are some extremely effective treatments, part of this umbrella treatment called cognitive behavioral therapy for insomnia, that are so very effective and actually cure the problem. And that, along with sometimes if medication is needed, that this is not something that somebody has to sit and suffer with. There are treatments for this and for really all the sleep disorders.
Great. Dr. Grant.
So I would say, again, if you have snoring or irregular patterns of sleep at night, insomnia, excessive daytime sleepiness during the day, or any violent or abnormal, bizarre behavior at night, don't be afraid to mention that. They've done studies where patients don't mention it to their doctors. They're just afraid to talk about it. So don't be hesitant to talk to your primary doctor about it, and don't be hesitant to get referred to a sleep doctor. The gratifying news about what we all do here is we're typically very, very, very successful in helping patients and treating the vast, vast majority of patients in feeling better and having a better quality of life.
Yeah, I think that's the upside there is there's help, there's a treatment, and you can have a good night's rest if you just get the appropriate care. So, and Dr. Jaramillo, final thoughts?
A great resource I give a lot of my patients is the National Sleep Foundation website, which is sleepfoundation.org. You can get a lot of helpful information on sleep hygiene, on tips for dealing with insomnia.
Great.
And if I could give just quick bullet points on kind of the best recommendations I can give with relation to sleep is, keep caffeine to a minimum, definitely in the first half of the day. If you're going to have a glass of wine, have it with dinner and not too close to your bedtime. Exercise, implementing that into your routine, again, preferably in the first half of the day is probably better. And if you kind of stick to those things, it's going to help you avoid these things.
Right.
And because this can make
Great
things
tips.
much more complicated. And there's a huge movement now in the sleep world, moving away from sleep aids and more towards what Dr. Wasman does, which is cognitive behavioral therapy. Because again, it's empowering patients. It's sort of giving the power back to the patient to be able to find sleep naturally, which is what we want.
Great. Well, we really appreciate you all being here. This is a great discussion. We may have to have part 2 of this discussion, but for more information, visit baptisthealth.net/sleep. And if you or your partner, or you have somebody, a friend that you think needs, some information about sleep, feel free to message us on Facebook. We'll be happy to direct you to any of our experts here today. They are great at what they do, and like we mentioned here, they really do help people get back to sleep. So again, thank you for joining us. Feel free to keep asking questions, and we'll see you next time, our next Facebook Live. Take care, guys.
Bye.
Thank you. This was great.
Thank you.